Okay, I think we should get started. Welcome everybody to the breakout session entitled When Assessing Infection and Sepsis in the ED, Think Patient, Not Pathogen. Use the immune response for diagnosis and COVID severity risk prediction. This breakout session is sponsored by Inflammatics. My name is Oliver Liesenfeld. I'm the Chief Medical Officer at Inflammatics, and I will introduce you to the program. So we at Inflammatics think that the immune system is actually a universal diagnostic, and we feel that our groundbreaking computational techniques produce mRNA signatures that can help in diagnosing, prognosing, and treatment response prediction. What we do is we mine public and private databases to generate RNA panels that consist of multiple target genes. We then use our proprietary, highly diverse and also physician phenotype data sets to generate and confirm that these data sets and gene panels are highly appropriate. We then use data normalization, platform transfer, and other engineering features that can be summarized as proprietary computational methods and generate results that are read by neural networks to interpret the gene expression levels. How we have applied this to different disease areas is shown on this slide. Inflammatics has a deep pipeline of novel and rapid host response tests that range from the diagnosis of infections and sepsis from blood to the prediction of severity of COVID, to other tests that are run from capillary blood or nasal swabs, to areas that are outside of the infectious disease space, like a response prediction for biologicals like anti-TNF, but also for the classification of metabolic diseases like NASH. All of these offerings will in the future run on our proprietary mRNA system, which is a rapid, highly multiplexing point of care system. This system will need less than 2 minutes of hand-on time to enter the cartridge into the instrument, read the barcodes, etc. And the results of the instrument will be generated in less than 30 minutes to be actionable in the emergency department or other areas. The workflow we envision is that you would draw a whole blood sample with a vacutainer, in this case, the PAXgene RNA tube, would enter it into the proprietary cartridge, into the proprietary mRNA instrument, and then in 30 minutes, LAMP or isothermal amplification would run on the instrument to generate gene expression results. These results will be read on the instrument with our proprietary algorithms, and you will generate test results that in the case of our INSEP flagship test will consist of the likelihood of a bacterial infection, the likelihood of a viral infection, and the severity of the condition. Why do we think that these results are actionable and highly valuable, especially in a triage setting? When you get 3 results, the likelihood of a bacterial infection, the likelihood of a viral infection, and separately the severity of the condition, these are all expressed in these interpretation bands that are shown here on the left-hand side in the color coding. They range from very unlikely to very likely to maintain high sensitivity and at the same time high specificity of the test. On the right-hand side, you can see the potential actions that can result from a result presentation as it's shown on the left. And this can range from the question of whether or not to administer antibiotics, whether to consider other differential diagnosis. In the case of the viral infection likelihood, you will consider to use antivirals or to apply isolation procedures or again, other differential diagnosis. And lastly, the severity result can help you to make disposition decisions. For example, whether to send a patient safely home or whether to admit a patient to the hospital. In today's session, we have 4 faculty that are kind of well known in their field. They're diverse and come from different continents. We have Jim Ducharme from Canada, who will be our moderator today. He's a professor at McMaster University, and I will hand over to Jim to lead us through the program. If you have questions to any of the speakers or the overall content, please put them into the chat that you can see in the meeting, and we will have a short Q&A at the end to answer your questions. Thank you very much. Jim, so I think you're...
Yeah. No, I'm okay. So we're going to talk today about how we can look at the clinical situation, where we are. There's many of us who think, well, we're already taking care of septic patients the way we should. We just hit them with large broad-spectrum antibiotics if we're not sure what's going on. Why do we need all these tests? Well, we're going to go through that, and I'm starting this off with a discussion of the clinical work, followed by the research and investigative work that our panel is going to discuss to show why RNA, messenger RNA testing is so important to our clinical practice. So this is a case. When you get inundated with COVID as we have, we went through what we call our third wave in April and May here in Canada, where we had variants from the UK and South Africa, where unfortunately our length of stays in the ICUs went up as long as 30-day averages. Ward averages 21 days, and we overwhelmed their system in Alberta and in Toronto, where we had literally ICU tents outside our hospitals with the third wave. So when you get into a situation where there is lots of cases of COVID, your brain becomes conditioned to think a certain way, and this is a great case that we had just recently. A 37-year-old male presents with a 3-day history of fever, dry cough, and weakness. And I can tell you, when this gentleman showed up, everybody who saw him said, oh, here's another case. What's remarkable about the third wave in Canada is because the elderly population has been vaccinated. The average person who's getting admitted to our ICU is now in their early 40s or early 50s because the elderly population has been vaccinated. So this gentleman had a typical presentation. He said he was weak, that he had no energy. His oxygen saturation was low when he was working and his breathing. Everyone who saw him, myself, the intensivist and the internal medicine physician, all agreed that he had COVID pneumonia. They needed to be put on Optiflow and go to the ICU. Of course, in Canada, right now with the third wave, in certain parts of the country, if you're on Optiflow, you don't get to the ICU because the ICU is filled with ventilated patients, and with Optiflow, you usually go to the ward. But we tested this guy with our rapid test 3 times because no one believed the results because his COVID swab kept coming back negative. His initial lab screening had showed a troponin of 10, which we had attributed to the myocarditis sometimes associated with COVID, and unfortunately carries a very high mortality rate. But his second troponin rose, and his third by 12 hours was 24. So despite a dry cough, fever, weakness, and the fact he had had fever for 3 days, it was determined in fact that he had a 17% ejection fraction due to severe triple vessel disease, and those fluffy alveolar infiltrates embarrassingly all disappeared with the use of a diuretic. So the question that came about, well then how did we get this so wrong? Well, some of it is of course context bias. You see so many cases of a certain disease, everything seems to be that disease. Some of it is that we think we know what we're doing with the tests that we have. We didn't think that someone with congestive heart failure and triple vessel disease would present with a dry cough and a fever. So we need to better identify sepsis and how to rule it in or how to rule it out. The frustrations, of course, that we have is we are very imperfect in how we do that. Only 20 and 25% of people with SIRS criteria actually have a bacterial infection. And Lord knows with all the COVID cases and the influenza cases, they all met SIRS criteria. Only 20 to 25% of febrile patients with febrile neutropenia have a bacterial infection. And of course, of those who are septic, 20 to 25% don't have a bacteremia, which means that a blood culture, even if it was very rapid, doesn't identify a fairly large quantum of our patients. We all agree that we don't have adequate antibiotic stewardship. We overprescribe because we feel in many cases they meet the criteria. We have to give them antibiotics. But how do we narrow the focus to avoid all of the complications you see listed here? Antibiotic-induced diarrhea, C. diff, bacterial resistance patterns, allergic reactions, prolonged QTs. It goes on and on and on, the side effects and the adverse effects of antibiotics. And unfortunately, we like antibiotics. This is a statistic that showed that 5 out of every 6 people in the United States receive an antibiotic prescription every year, most of whom don't need it. What's a very telling statement is that if you look at this slide, there was a study in 2019 that showed that having a positive test for influenza didn't decrease the rate of antibiotic prescriptions. We keep saying, well, if we do a bedside test for influenza and we know they've got influenza, we don't need to do any other tests and we don't need to treat them. But in fact, doctors didn't change their rate of prescription for antibiotics, even when they knew the patient had influenza. Curiously, they prescribed their antibiotics for only 7 days instead of 10 days because of the results of the test. We can see that a lot of this is out of our control. The most common cause of bacterial resistance is the indiscriminate, uncontrolled use of antibiotics in feed for animals, which I know Europe has tried very hard to control. But in many countries, patients can buy antibiotics out over the counter and then take them or sell them and use them on an intermittent basis. So what do we need to know to get better at this? We need to know, can we know for sure there's a bacterial infection or is it viral? And if it is bacterial, what subset is going to go into severe sepsis or septic shock? How do we identify those people so that we can maximize use of our resources? We're not very good at identifying them in the emergency department because 50% of people who go into severe sepsis or septic shock in the 24 to 36 hours after admission, we can't identify and predict in the emergency department. Clinical exam and current lab tests are of almost no predictive value for identifying that 50% that we don't identify in the emergency department. And even if we could predict sepsis, we have to remember that sepsis doesn't equal bacteremia. I get bacteremia when I brush my teeth. Nurses give patients bacteremia when they put in a Foley catheter. Bacteremia is not necessarily disease. There's lots of people with SIRS criteria who aren't septic. There are many septic people who don't have bloodstream infections. So the overlap amongst these various conditions isn't very good. Sepsis does not equal bacteremia. So what do we have right now? I live in a world where lactates are the culture of my society, where everybody wants to lactate, everyone wants to know what's going on. But unfortunately, a normal lactate today doesn't mean you won't be very sick tomorrow. Elevated lactate today doesn't mean you're septic today. It just means that you're not perfusing well or that you have ischemic tissue. A white count is essentially worthless unless you're neutropenic. Q-SOFA is very limited in the information it gives us. SOFA requires a 48-hour delta, but Q-SOFA gives us 3 pieces of information. The news scale is good at telling you who's sick in front of you, but not who will be sick tomorrow. So we're still in that place where we don't know how to identify those with potential bacterial infections who are going to get worse. We could talk about various ways of looking at the blood, but the problem is you require a positive blood culture for matrix-assisted laser desorption ionization or for PCR-based assays, and it takes at least 24 hours to have a positive blood culture, which is far too late for us in the emergency department. So what are we going to do? As was stated by Oliver, we can test the patient, not the bacteria. identify people at risk of deteriorating with novel markers, developing a test to know if it's bacterial or viral right from the start. So therefore knowing who doesn't require antibiotics at all. The list on this page is way too long for you to read. As you can see, lots of people are trying lots of ways to figure out how to test the patient. This particular topic is about transcriptomics and use of INSEP and 25 messenger mRNAs, which seems to be very promising. Other criteria, CRP is not very effective. Procalcitonin seems to be helpful with some respiratory conditions. There was all sorts of various markers being studied by various companies, none of which are very close to market as of yet. We have to remember that we were good with bacteria for 50 years. We could develop antibiotics that were that had bacteria highly sensitive to them, but resistance has grown very rapidly, and bacteria still rule the world as a result. We ignored coronavirus in 2003. It devastated 2 cities, and everyone in the world ignored it. Neither Hong Kong nor Toronto established systemic ways to prevent spread of this virus, even though they were very hard hit by SARS. So both Toronto and Hong Kong were at risk when COVID came around. Even talking about the pandemic, we have to remember that these 3 conditions have the highest mortality numbers worldwide year after year. Bacteria still work. Parasites still kill. So what are we going to do in the next 45 minutes or so? We're going to shed some light on how we can distinguish viral from bacterial, how to predict the risk of clinical deterioration, and show how we can do this at the bedside in the emergency department. Thank you for listening to this opening presentation. I'm now going to transfer on to Dr. Wolfgang Bauer from Germany for his presentation.
Hello. My name is Wolfgang Bauer from Berlin, Germany, and I'm looking forward to present you to this informatics. My only conflict of interest here to mention is that we were supported by informatics for conducting this trial. In 2018, Oliver Liesenfeld from informatics visited our emergency department and introduced us to the idea to give us emergency physicians the possibility to forecast the outcome of the patients, to decide if it's an infection, viral or bacterial, and all these tests in one single test combined. So of course, we were immediately interested to try these tests out in our ED. The Charité of Berlin is one of Europe's largest university hospitals. Our emergency department is one out of 3 university EDs out of the Charité located in the south of Berlin. We see around about 65,000 patients a year, and we are a so-called quaternary hospital, what means that we see a lot of patients from our specialized departments like hematology, rheumatology, or cardiology. So we are regularly seeing immunocompromised, neutropenic, and multimorbid emergency patients. And these are the patients in which we have to deal a lot with acute infections and, of course, with sepsis. So we decided to conduct a prospective non-interventional trial to evaluate the informatics INSEP test. We chose quite a simple study design with simple inclusion criteria. Adult patients coming to our emergency department with clinical suspected infections and at least 1 change of vital signs. The patient received a standard of care treatment, and we draw an extra blood sample in a PEX gene RNA tube, which was sent to informatics and analyzed in a nanostring encounter. Of course, we also get results for the INSEP severity test, but these results are not presented here today. To analyze the patient's outcome and to decide whether an infection is present or not, we performed a chart review, including all available clinical findings, like X-ray results, blood tests, microbiological findings, and of course, complete progress of disease, including a 30 and a 90-day follow-up. As a result of these reviews, we developed a clinical adjudication in 1 out of 4 groups: rule out an infection and rule in a proof an infection. And if there were some inconclusive findings, the adjudicator could also choose unlikely or probable infection. This was done independently for bacterial infection and also for viral infection. To evaluate only the clear cases, we chose the so-called consensus adjudication, which means we only analyzed patients with a proven or with an absence of infection ruled out. An important part to mention is that the adjudicator were unblinded to the PCT and CRP results for every patient, but blinded for the INSEP test results. So out of 312 patients with an initially clinical suspected infection, we found 56 patients with a bacterial infection and 24 patients with a viral infection. Just a quick view into our patients' characteristics. We enrolled quite old patients, which is in fact as we expected for our part of the city here in Berlin. To measure the severity of our patients, we used the Quicksilver Index, and we found 25 of our patients as critically ill or with a potential poor prognosis. And around about 20% of our enrolled patients were immunocompromised. To assess the INSEP test results, we created receiver operating characteristic curves, and we could show the ability of the INSEP test to differentiate between infection and non-infection significantly for bacterial and for viral infections. To compare the performance, we also analyzed the PCT, C-reactive protein, and the white blood cell count. And once again, PCT and CRP are tough sparring partner because the adjudicator used them to decide if a bacterial infection is present. So it's even more interesting that we could find a comparable, maybe even slightly better result for the inflammatics INSEP score than for PCT and CRP and PCT. For viral infection, we found also good performance. And as you can see, all the other routinely used biomarkers are of course not useful to assess viral infection. To translate the inflammatic scores into clinical actionable results, we transferred the test results into 4 different interpretation bands. We used previously established cutoffs and could achieve a high specificity to rule in an infection for bacterial infection, and an even higher sensitivity to rule out an infection, which means by getting a high test results, we won't miss an infection, and we can be pretty sure avoid antibiotics in patients with a low test results. And as you see, nearly the same results for viral infection. Another point I would like to mention is that we performed a subgroup analysis to make sure the INSEP test will also work in immunocompromised patients. By using a Mann-Whitney U-test, we could show that there's no impact in the test performance by the patient's immune status. So to summarize the trial, we found high accuracy of the INSEP test to identify a bacterial infection, at least comparable to PCT, but with the bias that the adjudicator used the PCT for adjudication. The viral score also performed well, and the test performance is most likely not impacted by the patient's immune status. What are the limitations? Well, the gold standard, the clinical adjudication, is not perfect. We might miss an infection, and it's even more complicated. It's hard to prove the absence of an infection for the adjudicator. We left out in our adjudication the unlikely and probable rated patients as inconclusive with our consensus adjudication here. We will show these data in our forthcoming publication. High accuracy does not necessarily match clinical utility, so we need an interventional study, which in fact we are currently planning. For this interventional study, we can hopefully soon use the point-of-care device with a turnover time of 30 minutes. So we will get a tool to identify bacterial and viral infection with high accuracy in 30 minutes bedside. Thank you very much also to my team here, research team in Berlin, and thank you. And I will have the honor to hand over to Evangelos for the next talk. Thank you.
Hello, I would like to thank you very much. It's a great honor for me to be part of this symposium, and it's really a pleasure to be with you and to talk about one of my favorite subjects. My name is Evangelos Giamarellos. I'm professor of internal medicine and infectious diseases in Greece, but I'm also delivering this talk on behalf of the European Sepsis Alliance, for which I'm serving as the current chairman. So the idea, what we want is to be able to decipher between bacterial and viral infection, which seems to be relatively easy well before the COVID-19 pandemic. But now, during this pandemic, we know and we learn every day more and more that it's imperative that we can understand what the human host is telling us in order to deliver the correct antibiotics, in order to understand whether a patient has bacterial infection, whether a patient has viral infection. This is my conflict of interest disclosure for this presentation, and I would like to take over and go on from my other co-speakers today, and I would like to give to you the results of our prospective validation of the INSEP assay in 6 departments of internal medicine across Greece. So this is a multi-center trial. The trial is registered as the PROMPT study. It is registered at clinicaltrials.gov, and it enrolled 397 consecutive adults admitted in the emergency department. And the idea is to try to understand if there are differences when these patients, they have signs of acute infection, whether we can depict a bacterial infection or a viral infection. Of course, you know very well that we use the classifier that is based on the interpretation of the expression of 29 genes of the host, and it uses nano-string technology. So allow me to briefly acquaint you with the features of the study design of our trial. So apologize for this. So originally we have screened 400 patients who were enrolled in the emergency departments, and they had at least, their case history was compatible with infection, but on top, they had a change of at least one viral sign. We excluded 3 patients, and we left with 397 patients for which INSEP assay was conducted. However, to deliver to you the results today, we wanted to focus not to the entire patients, but we wanted to focus for the patients for which clinicians, our adjudicators, were certain either that they were suffering from a bacterial infection, either that they were suffering from a viral infection. So look what we did. We delivered in a total blind fashion the clinical data of these 397 patients to 3 clinicians. And we analyzed only 102 patients for which there was an absolute conformity between the 3 adjudicators, that the patients, they were suffering from bacterial infection or from viral infection. So first of all, I would like to acquaint you with the general features of this cohort. As you can see, they are evenly distributed, they are males or females. Their mean age is 62 years old. They are actually of Caucasian origin. Few of them were immunocompromised. And actually, I want to let you know that in this cohort, we had 10% of the patients who died. As you may see, the white blood cell counting or the CRPs or even the procalcitonin cannot really tell what will be the outcome of the patients, but I want to feature that these patients, they had comorbidities. The most common comorbidities was diabetes, COPD, and congestive heart failure. So allow me to acquaint you with the analysis. These are the ROC curves of the patients according to the adjudicated ground truth. This is how we call that there is an absolute conformity between the adjudicators. So what you see in the left panel as red and blue is the scores. Red for patients who have a bacterial infection, blue for patients who have a viral infection, and you can clearly very well see here that the higher the score, the higher is the likelihood for a bacterial infection. If you go not to exactly the second panel, but to the third panel, you can see the ROC curve that tells us how the score can perform in order to discriminate between bacterial and viral, and you see that the discrimination almost perfect. However, among these 29 genes, there are genes that are scoring in favor of a viral infection. And as you can see in the second panel from the left, for these genes and there is a pure conformity between what the score is telling about the high expression of genes denoting a viral infection for patients for whom there was an adjudication for viral infection. And of course, the ROC curve tells the same. And if you compare the area under the curve of the INSEP assay to discriminate the bacterial from a non-bacterial infection, you see that the area is higher than PCT, it's better than CRP, and it's better than the traditional white blood cell. So let's go in these tables one by one. Viral infection, that means there is a suggestion coming from several genes of the assay that this is a viral infection. And as you see in most of the cases, this corroborates with what the clinicians have said in red. Yes, there is a high likelihood for a viral infection. The same applies in the second table for bacterial infection, whereas the performance is not that good for PCT. So the sensitivity for diagnosis of bacterial infection, 95%, of viral infection, 96%, and of whereas procalcitonin gives a performance, a sensitivity of 86%. And somebody would ask me right now, okay, but you use this 102 patients, what happened in what we call forced adjudication? That means that there was not an absolute conformity between the three adjudicators, but what is happening for the cases where 2 out of 3 were voting for a bacterial of a viral infection. You will soon see, and I'm happy to announce that these results have already been accepted for publication in Intensive Care Medicine Experimental, that even in that case, the diagnostic performance and sensitivity is very good. As you have seen from the very beginning, a minority of the patients were immunocompromised. Again, the INSEP, in case of bacterial infection, performs very well. In case of viral infection, it performs evenly well. And I would like to go to what is really modern. From 397 patients with sepsis, because this study took place before the COVID era, we analyzed another 97 patients with COVID-19. These are their PAC genes. And you see that there is a linearity. So that means that exactly in the same good way the assay is performing before the arrival of COVID, it performs equally well now and tells you who are the patients who have viral infection, in other terms, because there is a pandemic now, who have COVID-19. Something which is also very important nowadays in the area of COVID, because you know very well that the big concern is whether there is bacterial co-infection in our patient. The assay is able to tell even about the presence of bacterial co-infection, so it's extremely valuable. So I would like to conclude that our findings, they point towards an overwhelming sensitivity of this bacterial score coming from INSEP that's better than PCT for the diagnosis of bacterial versus viral infection. However, the advantage over PCT is that how do we suspect for PCT in case of viral infection just because PCT is not increased. Here we have inherited genes which are pointing to arms, towards the likelihood of viral infection. Always there are sensitivities. There, especially for providing an absence of bacterial and viral infection. I'm pretty happy that you will see soon our data being published in ICMX, and also we are looking forward, as Dr. Barrow also said, for the next study that will be prospective, but also we're looking forward to an interventional study. Thank you very much, and I'm looking forward to the discussion at the end of the session. And I would like now to pass to our next speaker, who's with us, Dr. Larissa May. Dr. May.
Yes, thank you. Let me share my slides. Okay, I'm delighted to be here. Let me just, sorry, technically challenged here. Okay, so with no further ado, I'm delighted to close out this session discussing a multi-gene human immune response with a transcriptomic or mRNA signature from whole blood to predict disease severity in patients with COVID. Certainly, there's been a lot of interest in this topic, and we'll be presenting a little bit building upon what my previous colleagues talked about. These are my conflicts of interest. So just a brief overview of COVID-19. So we know, particularly in many parts of the world, that COVID-19 is continuing to spread rapidly and has a very wide spectrum of severity. So in some patients, we end up seeing asymptomatic or very mildly symptomatic infections, such as mild upper respiratory infection. We also can see severe or fatal illness, including hospitalization, mechanical ventilation, and death. And this, I would need to say, has disproportionately impacted persons of color. Particularly in California, we've had a great impact on our Latinx population. And so there's a disparity here that also needs to be addressed. Unfortunately, the current use prognosticators are really of limited value. So clinical scores, including laboratory studies such as procalcitonin and other biomarkers, such as CRP, have limited utility in terms of predicting who is going to become ill. Also, we know while imaging can be useful, particularly CT scans in terms of diagnosing typical patterns of COVID pneumonia, we know that those patterns that are bilateral mild pneumonia can also be found in other viral illnesses and other conditions, and can also mimic things like CHF, as we heard earlier. And also that biomarkers alone have limited utility for these conditions and distinguishing between viral and bacterial illness. We also know from our experience in emergency healthcare that we've had high volumes and escalating need for supportive care. Many times, especially at the beginning of this pandemic, we've had limited resources in terms of PPE and other diagnostic testing and reagents. And so we continue to struggle with managing these patients. We know that up to 30% of hospitalized patients, or at least adults, are admitted to the intensive care unit for respiratory support. And a substantial proportion of those critically ill patients also do end up on high flow oxygen, and many require mechanical ventilation. We know that there's been a shift also in the pandemic, as now many of our elderly vulnerable patients are vaccinated, and we're seeing younger and younger patients ending up in the ICU, and the variants remain of concern. So we also know that there are few existing systems really to be able to risk stratify patients. So many have identified biomarkers such as CRP and PCT, as well as D-dimer. However, these really are insufficient to risk stratify patients in many cases, and we sometimes are very surprised by who ends up in the ICU. Also, our decision to admit patients is increasingly informed by what hospital resources might be available. For example, if there's significant bed and staff shortages in hotspots, we're often trying to send patients home on oxygen and find other ways to figure out who is going to get sick. And the lack of these risk guidance tools really also undermines our ability to communicate with our patients, to communicate with families. And so clinical management, while we know much more about this disease than we did before, really still remains a bit of a struggle. So in terms of what I'll be presenting today, We'll be talking about a COVID severity test developed by Informatics, and I'll be talking about how this 6-host mRNA panel that is run from whole blood was designed to predict 30-day mortality, as well as the need for mechanical ventilation and critical illness. And we'll see that we can stratify patients into 3 different bands. So the vast majority of patients, almost 80%, will be in the low risk category. So most of those patients can be treated as outpatients, whereas about 13% of patients are in a high risk category. So they may be predicted to require additional critical care and mechanical ventilation, whereas 10 to 16% of patients will end up in this moderate category where you really have to use your clinical judgment in combination with other factors to manage patients. So the clinical applications of this test, an intended use of this test would be, for example, in the inpatient setting to predict severity. So which patients are you admitting to the hospital that might end up being at risk and going into respiratory failure, requiring mechanical ventilation? The impact, of course, of this is that you could rapidly rule out inpatient care for most patients and identify those patients that would be in that high risk group very effectively. And then in terms of the outpatient setting, the COVID severity test could be used to predict severity. For example, which patients are in the home setting that might ultimately progress on to need inpatient or critical care. And so if hospitalization is not medically necessary, home care could be implemented. And then, of course, as we know in emergency medicine, a lot of our patients really fall in this clinical gestalt borderline, and those patients perhaps could be tested by protocol. So for example, if during the ED course you notice that there were vital sign changes, that might be an indication to do testing. I should mention that this is really predicated upon the fact that you would have a SARS-CoV test result first. So let's talk a little bit about the discovery of this. You can see that that Informatics developed this test using a multi-cohort transcriptome analysis using array and RNA-seq. And so essentially there were 21 studies of our pre-COVID cohorts of approximately 700 patients in total of varying ages, severities, who had viral illnesses other than COVID. And then essentially they used a best-in-class gene selection to look at severe versus non-severe outcomes. And so that included 6 mRNA gene signatures that were ultimately thought to be the most predictive. I should mention that these studies also included patients that were critically ill, mechanically ventilated, or experienced mortality. And so a machine learning train algorithm was used with those 21 pre-COVID cohorts and validated ultimately with a COVID cohort to improve the model. And so this is the Leave One Study Out model. And so this I will show you really leads to generalizable results and external validation. So this tool is quite powerful. So in terms of COVID testing, this slide here provides an overview on how the 6 mRNA signature was validated using bioinformatics in the large data set of patients with influenza and other viral illnesses in those 21 cohorts I mentioned. So Informatics found that the signature was able to predict mortality with high sensitivity and specificity, and that yielded an area under the ROC curve of 0.91 that you can see in the results box. As clinicians, ROCs aren't particularly useful in clinical decision making, so the machine learning algorithm was used to report results into 3 actionable interpretation bands that you can see in the box above, from low to intermediate and high risk. And this was determined using preset likelihood ratio cutoffs. For the low risk or rule out band, there was a sensitivity of 85%. And for the high risk or rule in band had a specificity of 96%. Importantly, only 16% of those patients fell into the intermediate band, which made the results highly actionable. The risk score was developed with an intermediate safety margin, as I mentioned, based on these predetermined likelihood ratio cutoffs, and included low risk, healthy patients, community acquired pneumonia. So you can see here, based on the results, that you had this safe to rule out band, and it's okay to overcall in that red band where you have patients that may go on to more severe illness, which is typically what we would do clinically in terms of admitting patients. Excuse me. So then Informatics tested whether the signature that showed good accuracy in other viral illnesses, including influenza, also worked in COVID. So prospectively enrolled 100 patients in EDs in Athens, Greece. And the left panel nicely shows how the 6 gene signature plus the algorithm can classify patients into those groups based on severity. ranging from those healthy controls to non-severe, severe, and patients that ultimately died. And again, the AUCs here were 0.89 for this test compared to 0.73 for IL-6. And then this was validated in independent COVID populations in Europe and the United States, and approximately 1,000 have been enrolled over this period of time. So this slide looks at COVID interpretation bands. So similar to the process of using those non-COVID cohorts for discovery, here we're showing the data for those COVID patients. And at the top, you can see the sensitivity and specificity for the 3 different interpretation bands I mentioned. And the bottom shows the AUCs compared to other biomarkers and clinical scores. So you can see here, looking at, oh, sorry, let me go back. Oops. Something happened. Sorry about that. So you can see here, essentially, you have a variety of columns here that are defining the comparator AUROCs, looking at specifically the 97 samples where you had lactate available. You can see that the AUC dropped to 0.82. However, because lactate on its own was only 0.75. Even in this case, the 6-mRNA signature adjusted for the presence of biomarker and found superior results. Just to clarify, the columns include a number of samples, the AUCs next of the individual comparators, and then compared again to patients in all the samples where the biomarker was available in that second to right column. So generalizing, as we've seen in other viral illnesses, this overall concept of testing for any suspected viral illness and using these prognostic markers can be applied to other viral illnesses. So the approach that informatics uses, using that bioinformatics and very powerful machine learning, is really agnostic to the specific viral illness. We also know that this will not be the last pandemic. And so even the final easing or return to quote unquote normal for COVID-19, in terms of those of us who work with healthcare, will obviously not be the end of the need to improve risk stratification, even in acute confirmed viral infections. And so while COVID-19 has accelerated the need for these types of tools, it's predicted that this viral severity test would work in response, for example, to seasonal influenza, other influenza pandemics, and other respiratory infections, where again, emergency departments could get quickly overwhelmed. So in conclusion, the viral severity test will potentially be useful for any viral pandemic, using that signature that successfully predicts mortality in one data set or in the data sets presented are likely to hold up across acute viral infections as a conserved host immune response. And so mining of these databases really is that powerful tool. And we can use non-COVID cohorts to COVID cohort classifier. So that strength of approach really includes the use of public and private data for classifiers, which is much more powerful than previously developed techniques, because signatures can be generated in the data set that can then be applied to other data sets using that very powerful bioinformatics and machine learning approach. So the INSEP acute infection sepsis test that was presented earlier will incorporate some of these prognostic and diagnostic signatures for rapid actionable results in the ED. But it's been my pleasure to talk about some additional data that was done during COVID, given the importance of COVID in our current times. So with that, I will stop. And you can find out more information here at informatics.com, SAM21, and here is some contact information if you want to follow the company. And I think at this point, I will turn it back to Jim to go ahead and open the Q&A.
All right, Larissa, I just want to have a question for you. Thanks very much, everyone, for the great talks. Larissa, right now, when we admit people to the wards or the ICU with COVID pneumonia, we're putting them basically on 3 drugs: an antibiotic for bacterial pneumonia, remdesivir, and a steroid. How do we use this testing to perhaps stop using the antibiotic? Or are we still stuck with that?
Are you asking me?
I'm asking you.
All right. I knew if it was a stewardship question, it was going to come to me. Yeah, no, I think, I think the current technologies that we have really do have a lot of limitations. I always say that a diagnostic test is not going to be the answer to avoiding antibiotics completely, right? Because there is this level of diagnostic uncertainty, particularly in emergency department, where I think, and behavioral change is needed, that, you know, people may not trust the test 100%. You're looking at the individual patient in front of you. It's really hard in a patient that looks ill, as Nate Cooperman mentioned, to withhold antibiotics. So I see these approaches more for, you know, if the patient's being discharged and they don't look very sick and you think they have good follow-up, and this test, you know, seems to suggest it's viral, that you could provide some instructions with that regard. Or if they're being admitted to the hospital, but you're not sure if they are, you know, if they have a bacterial viral infection, but they don't look sick enough, you know, to go to the ICU, could you use this as a prognosticator and potentially withhold antibiotics? Now, for those that are really sick and look septic, or there's just other concerns or comorbidities, I agree that most of the time we're just going to go ahead and treat those patients as septic. Plus, you know, we have CMS measures that require us to do that, right? So I think that's not really going to change that first dose, but I do believe these tests do have a role in antibiotic stewardship.
Thanks. This is a question for any one of the panel members, and I apologize, it seems like a trap question, but I think it's worth asking. We as physicians have shown an inability to respond to data. We have done multiple studies that show that elderly patients have asymptomatic bacteria, and when we suspect people without symptoms to be septic from UTIs, we are consistently proven that not to be true. We have done studies looking at patients with influenza, proven influenza, and we ignore the results and give them antibiotics anyway. So we have a track record of ignoring evidence and using antibiotics. So any one of you, and I'll let Oliver or Evangelist or Wolfgang, anyone who wants to answer. So we're going to come up with a test that's going to show that it's not bacterial in a patient who's febrile, who shows up with SIRS criteria in our emergency department. Are we going to convince them now that antibiotics aren't required? Or is this a test that's going to be done and people are going to say, I'm still giving everyone antibiotics?
May I get the question?
Sure.
Yes.
Well, you know from my track record that I was one of those who have worked with procalcitonin and who has done the one recent study also published in the Blue Journal about the use of PCT. So that question that you just done is exactly the same question that everybody had in the world when the first PCT studies were done, telling that, look, you have an algorithm, and if a PCT is below that, you don't give antibiotics. If it's more than that value, you give antibiotics. However, 15 years ago, it was reasonable to have that type of question because that question has never been answered. Now that we know that the concept is working, and with INSEP, we have a working tool which is apparently more powerful than PCT. Why? Because PCT points towards the viral direction of an infection only when it is negative. Whereas on the contrary, the INSEP platform is occupied with genes that are per se diagnostic for viral infection. With this in mind, I don't believe that we are in need of randomized interventional studies. We can build on the PCT existing evidence, and having a tool which is much more powerful than PCT, we can have certainty that we are following the correct path if we restrain from antibiotics in case when INSEP is telling us that the likelihood for a viral infection is really large.
If I may add from informatics perspective, I think it's a dual strategy that we would like to pursue. One is obviously to get the evidence published, and I just put into the chat that the manuscripts for the presentations that Wolfgang and Evangelos gave are being accepted by kind of highly recognized peer-reviewed journals. And then secondly, obviously the company is preparing a lot of medical education work, so that the potential users in the future, when the instrument becomes available, and we expect this to happen in Q4 of this year in Europe or in countries that accept the CE mark, and then sometime next year when FDA cleared the test. So we are trying to put the evidence out into the manuscripts, and then we want to do medical education where seminars, other tools will be used. So this is what the company has planned. And then in terms of randomized clinical trials, these are required for the reimbursement of the test anyway. So we are pursuing this both for the countries that accept the CE mark and for the US as well.
So I'd just like to answer one of the questions that comes from Nathan Cooperman. Nate, you said that we showed that PCT was highly sensitized in identifying those with viral disease for pneumonia in kids. I would say Nelson's textbook of pediatrics since the 1960s has said that's just not a good study, because most kids with pneumonia have viral pneumonia. And so you already have an underlying rate of viral illness. It's so high that I'm not sure that the PCT adds much. There is a huge desire to treat those children with antibiotics, but in fact, in many places in Canada, if you're a well-looking child who comes in with a cough, you don't even get a chest x-ray, because even if we find something, we're going to conclude it's viral and not treat you anyway. So we have to be careful that we're looking at the underlying rates of illness and what type of illness when we're looking at these studies. There's a lot of discussion on the chat about PCT. I think Oliver has mentioned that this is going to be looked at, and that, like I wrote, we're not competing, we're trying to complement to get the best possible result for the patients. We are now at 3 minutes before the end, so are there any last comments from the panel?
I think I was just going to say that I think that the strength of this approach, and I think this is where a lot of diagnostic testing and other prediction models are really going, is the power of artificial intelligence and machine learning to really do things that the human eye or the human brain cannot do. And I think, there's been a lot of experience in this, but I think like any other diagnostic testing, it's going to take some time for people to become comfortable with the concept of machine learning. But I really do think it's sort of like big data. It's harnessing, information that is really going to be helpful, I think, for the future. But it's going to take a little bit of convincing, I think, like it did with PCT.
Well, I think that, and as Nathan keeps writing in the chat group, listen, I'm a fan of PCT. My biggest problem is that I can't get it done in a timely fashion in my hospital. I wish I was where he is and that we could do PCTs more often, because for antibiotic stewardship and for getting people on or off antibiotics in respiratory illnesses, I think the studies are very clear in its results.
Yeah, even then we've still had trouble with, particularly with adult emergency physicians getting buy-in into PCT.
Right.
Even though there are studies, I think there's been some confusion with PCT because, there's been some, for example, the very large New England Journal of Medicine study looking at, I believe it was 14 randomized, like an RCT of 14 hospitals that implemented PCT, looking at patients that were being hospitalized for lower respiratory tract infections. And I think there's still this desire to treat the patient with an antibiotic that is so strong when you've already made that decision that the PCT result, it's almost like it's at the wrong place in the workflow. So I think for future studies and RCTs, we also really need to consider workflow and how ED clinicians think, and really match the diagnostic testing and the other tools we're providing to really integrate that clinical decision support that I think is still lacking right now.
All right, Oliver, you get to have the last word.
Thank you, Jim. No, I just wanted to add one comment to the question of PCT versus what the INSEP test would do. I think our current vision is that the INSEP test would be used early on in triage. And let's not forget, this test is not only providing a diagnostic result, but a prognostic result at the same time. So you have a combination of these two that people need to be familiarized with. And then we have not done studies. There was a question of somebody about the question of getting patients off antibiotics when PCT is falling. We have not studied this in detail, what the INSEP test does in this setting. We have some studies ongoing in ICU populations where we monitor patients over time to see how the scores in the INSEP test develop, but that's not ready for prime time. So I wish to thank our faculty, everybody, for wonderful presentations. I hope the discussion was lively and helpful. I think everybody who attended this session, if you have any questions to what Inflammatics is doing, please reach out to us and we will continue to work on circulating the evidence that we are generating. Thank you very, very much. Bye-bye.